All right. So can everybody, I think we're all a go. So it turned out that today we're talking about progesterone, but in a very specific way. And the reason we're doing this is that in our pro membership today, which is our 5th time that we're meeting without having any of the free meetings being counted, this is the 5th pro meeting. And it was based on a question that Deborah sent in yesterday late afternoon. So it kind of changed everything in the last hour. So she said, can you discuss the vaginal versus oral progesterone and uterine protection? I know that you have said that oral doesn't protect the uterine lining, and that's not totally true. It doesn't do near as good a job as vaginal, which trumps even topical. But vaginal and topical, is we're going to go through the evidence, definitely trumps oral, and we're going to discuss what this means and the confusion around it. And she said, but this doesn't fit with what I've seen in clinical practice. The regular doctors don't think the topical does anything, and of course they use it vaginally for fertility treatments, but oral progesterone has been used in various forms for so many years, specifically for uterine protection. So we're going to go through the data on that. And then when she says, I don't see women having uterine problems, I have to tell you, if a woman has a uterus and you start her on hormone replacement, and sometime within the first year, you're not doing a vaginal ultrasound and taking a look at her endometrial stripe, you really don't have any idea what's going on in her uterus. Now, of course, if there's spotting and the spotting is not involved with altering dosages of progesterone, you got to track that down, because that could be one of the signs of having a proliferative endometrium. But as you're going to learn, even with high dosages of progesterone, especially orally, in studies, when they do endometrial stripes, they have some evidence of hyperplasia activity. And I'm going to share a very interesting story that took place with a medical doctor that I see that was on hormone replacement and made a specific change and ended up having an endometrial stripe that went from her 4 that we had started working with her at to 26, and why that what was and what we did to fix that. So the rest of Deborah's question is, I guess I'm wondering, how strong is the evidence, which is what we're going to go through today. Is it that topical has more benefit compared with oral? Does the literature say oral has no benefit for uterine protection? Was there one article or a whole body of research? And you're going to see that there's been a whole body of research. Is it more expensive? It is more expensive and more work to add topical progesterone in addition to oral. That is true. And so many women love how they sleep on oral. So I am not saying that oral should be thrown out the window, but I'm saying that you really need to have a good understanding of which route of delivery creates which potential benefits and issues on your patients. So I love that she wrote this question in, and I felt like this was a great question, great question. She said, this is sort of rocking my world, which is why I gave it my attention. This is the sentence I got later on in the day yesterday. This is sort of rocking my world, so I want to learn more. Thanks. So I'm just going to do a very, very short little intro, because most of you know this, but progesterone is not progestin. But the problem is so many scientific articles confuse the two, that a lot of gynecologists, a lot of researchers really just don't understand the difference between the two. And I hear at conferences a lot that are allopathic, a hormone is a hormone is a hormone. Here's just 2 articles right here that within the abstract and the body of the article, they completely interchange the use of progesterone and progestin. So that's one of the issues of progesterone. I know you know this, I'm just laying a little bit of the groundwork that I wanted to go on to the evidence, talking about the difference between the routes of delivery. Progestins differ greatly. They're the synthetic from progesterone in form and function, but they both do protect the endometrium. We know from Helen Leonetti, she was a girlfriend of mine who in the 80s, she did randomized controlled trials and showed that if you gave topical progesterone versus progestins, and she tracked women for 6 months and did endometrial stripes on them, both the progestins and the topical progesterone, that's what she used. Helen Leonetti kind of put progesterone on the map with her initial 2 studies that she did. protected the endometrium from the estrogen's stimulation, where you have the lining growing a bit out of control. Progestins don't perform any better than progesterone, but they carry all these different health risks that have to be considered for long-term therapies. So you have to even think of this when a woman is on oral contraceptives or an IUD that has progestins. So what we're talking about with progestins in a postmenopausal woman actually is applicable. For example, progestins are very bone integrity harming. And so one of the side effects of, I think, of long-term use of contraceptives is that we have a higher increase of osteoporosis in women, even at younger and younger years. Topical progesterone has been shown to effectively reduce estrogen's mitogenic influence on the endometrium, such as its proliferation. Oral progesterone is also protective to the endometrium, but excessive oral progesterone is very short-lived. Most goes into metabolites that do not protect the lining of the uterus. And I'm going to show you all this data, the studies where they gave different types. We're going to go through that. And there's also the issue that if you give more oral progesterone than you need, some of these metabolites, the pregnane metabolites, might increase the risk of a woman's susceptibility to breast cancer. This is based on a Canadian biologist named Weeb. I'm going to present his data. This is new data. He just started publishing this a few years ago, and Jonathan Wright just started making available the pregnane metabolites of progesterone, a test available through Meridian, but I have found it to be very, very confusing. But I'm going to share with you what I know. But I have found it, we don't know enough about it yet to say it's set in stone. But the bottom line is that when you take oral progesterone, it makes metabolites. Some of them are brain calming, sleep producing, as we know, but some of the metabolites cause proliferation at the breast, when we've always thought of progesterone being a policer of, or an inhibiting factor of estrogen, but it's much more that way at the lining of the uterus than it is in the breast. Testosterone, as it turns out, is much more anti-proliferative at the breast than progesterone is. And you're going to understand why, hopefully, by the end of this talk. But remember, I put this together. She gave me this question yesterday in the afternoon, so this talk has been made since then because I thought it was such a great question. Topical progesterone achieves much higher cellular and blood levels of progesterone than oral. And we're going to go through the studies that test that. The most efficacious and safest way to protect the endometrium is with topical progesterone. And so we're going to look at the evidence. It doesn't mean that oral doesn't do it, but it does not do the same job. And when you say you've never seen any problems, does that mean within the first year on all of your patients, you have done vaginal ultrasounds and tracked their endometrial stripe? Because I don't know if that's true. And I wanted to bring one other point up. So here, I just interviewed Dr. Brownstein on my show. We posted his show last Monday, and he said it took him so long years ago when he first came out with his miracle of natural hormones to show the natural progesterone molecule and the progestin molecule. And when you look at the two, you can really see the difference. And part of this difference is that it's got a totally different shape. And what I wanted to point out is that the receptor is malleable to take a ligand. Here's a ligand into the receptor. Tom Bishop did this was one of the first visuals of a computerized receptor and a hormone docking. This happened to be estradiol. It wasn't progesterone. But the problem is if you go back to the change in shape, if you go back to the change in shape, it doesn't necessarily mean with a different altered shape that that's now going to fit into the receptor. Some women might have more malleable receptors than other women. Some women might have more endocrine disruptors inside the receptor already, so they only have so much room, so they can't handle any change in shape. And we don't often think about that. This isn't part of the question, but I thought it was really interesting to see this. And I just wanted to bring this up again. Here's a target tissue. I think you've seen this already, and I shared this audio video in the class that we did a few days ago, but it really brings into your mind with this graphic what's going on and why progestins might be much more variable in how one woman's body responds to them versus another. And it might have a little bit to do with how one woman responds to oral versus topical, because everything is, the metabolites of progesterone have a different shape. We're talking completely about shape. and hormones dock and they signal based completely on shape, and metabolites progesterone are based on shape, and the progesterone receptor, which there are two isomers, is set up to receive this shape. But when you take oral progesterone, it has now different metabolites that have different shape, and it might vary between woman to woman who could handle that shape. So there's differences when you swallow progesterone. You're making allopregnenolone and pregnanes and different metabolites, and it all depends on the malleability of the receptor of a woman, whether that receptor can receive that shape and then shimmy in space and deliver the progesterone signal to the gene in that cell. Now, we know that progesterone gets its name because it supports gestation, and we're going to go by the end of this talk and say what are the most common dosages that we use for oral, for topical, for vaginal. But the body is set up at pregnancy to receive 400 milligrams a day, and Katerina Dalton, who's the woman, the British physician who came up with the term PMS and was the first woman to give progesterone for PMS, she was a forensic physician, and she was getting women, she was part of a legal team to help protect women from having to be found guilty and put into jail for either shaking a baby to death or murdering a husband, because it occurred in the premenstruum. And she was able to show that if a woman was insufficient in progesterone, she could have manic and murderous behavior. And she published over 55 articles in peer-reviewed literature, and she gave progesterone as suppositories, and she gave it up to 800 and 900 milligrams a day, and she gave it to women for years on end at that dose and published that. So in the literature, we know that dosing goes anywhere from 10 milligrams to 800 to 900 milligrams. And how are you going to give that? And when would you give it and why? So by the end of this talk, hopefully we'll have some idea about that. Progesterone is breast protective and reduces the risk of breast cancer. In the Women's Health Initiative reanalysis that came out December 19th at the Breast Cancer Symposium in San Antonio, we saw that giving natural progesterone reduces the risk of breast cancer in healthy women, while the use of progestins increases the risk of breast cancer. But Avram Blooming is taking even umbrage at this, and he's claiming that progestins don't have this, and he has a methodology. He has a number of letters to the editor out since December of last year saying that he doesn't totally agree that progestins are bad, but pretty much everyone is saying that progesterone is not only uterus protective, but now we know it's breast protective. And based on Avram Blooming's book, Estrogen Matters, he presents 10 human trials with controlled cohorts in breast cancer patients given estrogen. It's often as estradiol or Premarin, conjugated equine estrogen, and they have reduced recurrence and reduced mortality if they do get it, and that's giving estrogen, but progesterone can't work unless there's estrogen on board. This is some of the articles that just support what I just said, so you can take a look at that yourself. We know that progesterone taken orally promotes cognitive function and calming neurosteroids. Pregnenolone, allopregnenolone, while progestins increase the risk of cognitive decline in Alzheimer's in some articles up to 100%. And I gave some of the citations down here. Progesterone benefits the heart, while the use of progestins does the opposite. When I was a student in Oregon, they were starting at the University of Oregon to give progesterone to rhesus monkeys and show that it could cause vasospasm and progestins and contribute to stroke. So we know that there's this big difference between these two. We also know that breast cancer will be diagnosed in 1 out of every 8 women, while uterine cancer only occurs 1 out of every 3,700 women in America. So uterine cancer cases are currently 27 cases per 100,000 women. So a woman between the age of 45 and 65 years old is more than twice as likely to die from cancer than heart disease, and breast cancer is the leading cause of death. So we want to make sure that when we give hormone replacement, that we are protecting the lining of the uterus, and we are also protecting the breast. That is the goal of how we give all this, and we have to say what are our biomarkers and what is the evidence for this. So we want to treat a woman to protect her endometrium, but that doesn't put her breast at risk. So we don't want to create any problems, and that's what we have in mind. So estrogen is the mitogenic factor leading to any pathologies. Now, this is old, not to the breast, because that's old thinking. We no longer think that estrogen leads to pathologies in the breast, but that's what you read everywhere when you look at the literature. But we do know at the uterus that when you have excessive estrogen stimulation, which is where progesterone calms that down, this can lead to endometrial cancer, endometriosis, uterine fibroids, and the debate is on with breast cancer. So when a woman has a history of endometriosis and uterine fibroids, you want to think this woman has not been getting enough progesterone signaling at the lining of her uterus. Estrogen stimulates while progesterone inhibits endometrial growth, and progesterone antagonizes estrogen-driven growth in the endometrium, and insufficient progesterone action strikingly increases the risk of endometrial cancer. So if we give oral progesterone, how much is getting to the uterus wall? If we give topical, how much is getting to the uterine wall? So we've thought of progesterone as the policer of estrogen. Everybody says that. Progesterone helps control estrogen, but it's mostly in the uterus, and we're going to go through the data on that. But is there enough with the route that you're giving to get there? And if you're not taking vaginal ultrasounds in your women, you don't really know, even if they don't have spotting and symptoms. So I do believe that when you're starting to work with any woman that has a uterus within the first year, you got to do a vaginal ultrasound. In the adult mammary gland, the progesterone receptor is not expressed in all cells. It's only 7 to 10% of epithelial breast cells are PR positive. So how could progesterone be a real policer of estrogen or of growth out of control in the breast? And the PR positive cells are usually not the cells that proliferate. So progesterone needs estrogen to act in breast tissues. Progesterone helps rinse estrogen so it doesn't bioaccumulate in breast tissues, but the majority of human breast cells that are proliferating are PR negative. So progesterone is not so much a protector in the breast of keeping hormones at a zen state. It's more testosterone. And I've got a book called Hormones in Breast Cancer Survivors, and that goes into all the research on testosterone at the breast. This was a double-blind randomized trial where they gave topical application to the breast of a gel containing either placebo or estrogen or progesterone, or a combination of estradiol and progesterone daily during 10 to 13 days preceding breast surgery. And they did this on 40 premenopausal women who were going to go in because they found a lump, so they were getting a lumpectomy. And what they found is whenever you gave extra estradiol, that increased the number of cycling epithelial cells. But if you gave it along with progesterone or progesterone by itself, it did significantly decrease the number of cycling epithelial cells. So even though the PR positive cells don't proliferate, progesterone to a certain degree polices cell growth in the breast, although it does it more at the uterine lining. And the conclusion was exposure to progesterone for 10 to 13 days reduces estrogen-induced proliferation of normal breast cells in vivo. So that's just one study. This question creates a lot of confusion for clinicians and for Deborah, who sent this in, which I love that she sent this in. So what we're going to do is look at the physiology and metabolism of the two different routes of administration to kind of get, or try to get, unconfused. So once you take progesterone orally, it's quickly and thoroughly metabolized by both the prehepatic gut microflora and then the hepatic first pass metabolism, such that very little unadulterated progesterone makes it to the breast and the uterine tissue. And these are the studies where this literature came from. In studies by this research team, they consistently showed that oral progesterone is quickly converted to metabolites and that blood and tissues levels never reach significant levels. It doesn't mean that there isn't some protection, but you have to understand that based on these studies, once you swallow progesterone, the metabolites that it breaks down into don't act at the lining of the uterus to oppose estrogen signaling. Given that topical and vaginal delivery methods bypass the early gut and liver metabolism, true progesterone is measured in the bloodstream is robustly present. And early studies of progesterone's movement throughout the bodies have now been reanalyzed, and they thought that the earlier methods where they took a look at the metabolites of progesterone didn't do a really good job up until the last few years with that Canadian biologist Weeb to understand. So we can't look at some of the older studies. They didn't have really sensitive pharmacokinetic studies. Chang showed that when radio-labeled progesterone was given topically, and so this is topical progesterone, and then measured in breast tissue biopsy that had high levels, they saw that as soon as it was given topically, there were high levels in the breast, even though there was very little seen in the bloodstream. So taking topical progesterone does go to the breast, even though it doesn't elevate the levels so much in the bloodstream. Whereas when they gave oral, very little of the dose went to the breast and appeared in unmetabolized in the bile. Another research team administered topical vaginal progesterone versus IM injections and then measured the blood and then did endometrial biopsies and showed superior tissue delivery using vaginal progesterone over even giving an IM injection. So vaginal progesterone gets progesterone to the lining of the uterus in all of the different studies that we look at the best. Vaginal is the best, topical is next, and oral is below that. So I wanted to share one of my patient's stories. So a medical doctor was seeing me for hormones, and she was doing troches, and she was doing Biest and progesterone in her troches for about 14 years, and said that she was fine, but she'd never done an endometrial stripe. She wasn't monitoring herself, even though she had a uterus. And all of a sudden, she moved to a different state and was using a different compounding pharmacist. That compounding pharmacist had a larger troche that lingered in her mouth longer. And within a month and a half, she started having spotting and bleeding. She was in her early 70s, so she went and got a vaginal ultrasound, and her endometrial stripe was at 26. And I had told her that when you take a troche, you still swallow some orally. The more oral estrogen you get, the more you're apt to get. It's very hard to get enough oral progesterone to police the amount of oral estrogen you get. I think she was taking Biest and progesterone together, both in the troche. It's very hard to have enough. And so I just said, what you need to do is not take it as a troche anymore, take it topically or take it vaginally, and take a little bit of extra DIM and methylfolate. And she did that. She just changed her delivery route. She upped a little bit of the progesterone that she was getting topically. And the next time she did her endometrial stripe, it was 5. And now it's down to 4. So Miles administered topical vaginal progesterone versus IM. So the topical showed superior tissue delivery using, superior tissue delivery was achieved using vaginal over even IM injection. I mean, that's pretty amazing. So the study by Levine and Watson is the most compelling evidence, as he administered either 90 milligrams of vaginal progesterone or 100 milligrams of oral, and then measured blood samples. The vaginal progesterone dramatically outperformed the oral, generating a much higher curve that lasted for a longer period of time. Not only was the vaginal gel greater in peak concentration, it also produced a long-term effect. So when you take the longest term effect of getting progesterone to oppose estrogen at the lining of the uterus is vaginal. The second is topical. The third is oral. You get some with oral, but as you're going to see in some of the studies, even at doses of 400, when they went in and did endometrial stripes, they saw some evidence of hyperplasia. But unless they're spotting, you don't know that any of this is happening to the patient. This study by Levine and Watson strikingly illustrates they administered 90 milligrams of vaginal progesterone or 100 milligrams of oral, and then they measured the blood values. The vaginal progesterone gel dramatically outperformed the oral, once again giving this really higher peak and longer peak. And not only was the gel greater in peak concentration, it also was much more long acting. So the conclusion was, and the name of their gel was Crenone, I think that's the pronunciation, given vaginally results in greater bioavailability with less relative variability, and that's a big point, less relative variability than oral progesterone, thus providing more reliable delivery of progesterone compared with oral progesterone. And this study came out in the comparison. The journal is Fertility and Sterility in March of 2000, so it's a 20-year-old article, but it was called Comparison of Pharmacokinetics of a Vaginal Progesterone Gel Administered versus Prometrium administered. So this is Prometrium. And remember, hormones come in different sizes, and some are cheaper and some are more expensive. So Prometrium is a larger molecule of progesterone. There's different grades of hormones. So sometimes a woman will be using one dosage that works perfectly, and she moves to another place and goes to a different compounding pharmacist who's buying cheaper sources of hormones, and they're larger. And some women can handle them and some women can't. Some women have that huge receptor that'll take a large Prometrium because they don't have a lot of endocrine disruptors in there, or they just happen to have genetically more malleable receptors that you just saw when we played that little music. And some women can't handle Prometrium at all. But this is a comparison of vaginal progesterone to Prometrium. And the vaginal progesterone gave a higher level, a more reliable level, and a longer term level than giving Prometrium, which is what's reimbursed by insurance and that a lot of women take. And some women can use it and do well with it, and some women can't. The metabolism of orally administered progesterone can leave the uterus and breast tissue unprotected. Topical applications, skin or vaginal mucosa, give more protection at both the uterus and the breast, but especially at the uterus. But there are, like Deborah said, dozens of studies that say that if you give topical progesterone, it opposes estrogen at the lining. So what's the story? This seems, why is there such a mixed picture of outcomes? So we're going to look at a little bit more and some of the other possible reasons. So now I'm introducing you to this guy. He's the Canadian biologist that started publishing papers. I think I have right in the next one. This is a number of papers. He started publishing around 2006, and 2016 is when Dr. Wright bumped into him, and now Dr. Wright has based his new test on Wieb's work. Wieb said, we've already seen that using oral progesterone leads to rapid breakdown in poor tissue levels. So the trend by some has simply been to increase the oral dose to create a larger pool of progesterone. Well, some women, you give them 50 milligrams of oral progesterone to help them sleep, and they go, well, I'm a little bit better, but I'm still waking up at 3 a.m. So then you go to 100, and then they go, well, it isn't until I get to 175 milligrams that I'm really having a better sleep. But what are the side effects of going to a higher and higher oral progesterone? Is it totally safe or not? And Wieb is saying this immediately creates a second problem. And the problem is you get to larger dosages of oral progesterone, you get now a production of secondary metabolites. That isn't just the neuroprotective allopregnenolone and pregnenolone, it's pregnane metabolites. And he demonstrates that the enzyme 5-alpha reductase can metabolize progesterone to these pregnane metabolites, and pregnane metabolites are much more pro-inflammatory and potentially breast cancer risk increasing versus the pregnine metabolites. So studies using various breast cell lines have shown that pregnane and pregnine have opposing actions in terms of cell proliferation and adhesion. So he's saying as you get into high oral dosages, you're not just making neuroprotective metabolites. You start making a whole set of new metabolites called pregnine and pregnane, and their ratio to each other dictates proliferative action at the breast. So some women say, well, I take progesterone and my breasts get really big. They would get really large because they have a lot of very active alpha 5 alpha reductase, and they're making a lot more pregnane than pregnine, and they're getting their breasts enlarged. So Jonathan Wright has developed a test where you do 4 days of topical progesterone, and then he measures the urinary metabolites and the ratio to each other. And I started doing that right when he brought that out. And a number of my patients were making more pro-inflammatory metabolites from progesterone than others. And when we reduced the amount, the women started having breakthrough bleeding. And it wasn't until we got back to their original levels before we spent the money on that test that they felt better. So I'm just presenting this to you, but I haven't known exactly what to do with this in the clinical arena yet. But there is this growing understanding that if you keep upping the amount of oral progesterone, you can start to create metabolites that you might not want. Jonathan does his test on topical progesterone, not oral, and he's trying to guide you on what would be a good level of topical to keep those pregnane to pregnine metabolites in a good ratio. You're going to hear more and more about this. I'm not really sure what to do with it, but because there is this growing understanding that as you go higher in progesterone levels, you can get some metabolites you didn't plan on. It's something for us to understand. How do we give the best amount to our patients with the least risk downstream? And these are some of his articles: progesterone metabolites in breast cancer, the mechanism of action of breast cancer promoting hormone 5D hydroprogesterone, which is a progesterone metabolite, progesterone metabolites that regulate induction, growth, and suppression of estrogen and progesterone receptor negative human breast cell lines. This is an in vivo test, but he has a big growing body of literature. So this is going to be up and coming. And I stopped using Jonathan's test because I found that clinically it wasn't working for me. But it's one of the reasons I'm very careful about the dosage I start at with any progesterone and try to accomplish what I want to accomplish without having to go to really high levels, especially oral levels. There is also a osteopathic doctor who wrote a very interesting article in the Townsend Letter, Gary Huber, and I thought I don't agree with everything that Dr. Huber has to say, but he said, from my experience in over hundreds of hormone replacement cases, when urinary progesterone metabolites are measured, it is rare that any woman can tolerate more than 100 milligrams of oral progesterone without aggressively producing excess pregnane, the ones that cause inflammation in the breast, metabolites. Now, I have a lot of patients that don't feel good unless they do 150 milligrams. So my upper dose of oral is really 150, 175, but I want to really make sure that their breasts aren't enlarging. When your breasts enlarge with taking progesterone, most likely that is a clinical sign of producing those pregnane. But it's very interesting. He teaches not to go above 100 milligrams because of this if you're taking it orally. This is a major risk concern, as I pointed out above, that pregnane puts the breast at risk, and breast cancer is already thousands of times more likely to occur than endometrial cancer. It just doesn't hold up to logic that we would attempt to protect the endometrium with a strategy that places the breast at greater risk, especially when topical progesterone approaches work better and with less risk. But, oral progesterone is what really helps calm the nervous system down and helps a lot of women sleep. So I do end up often now these days giving oral before bed in a sustained release dose, and we'll go over the dose range toward the end of this talk. And I also tend to in a vaginal, because vaginal gives you your best protection of the uterus, and also the Finnish studies. It was published in ACOG in 2008. There was a PhD student who looked at 140,000 women in Finland, because it's a socialized country and they're given hormones when they become menopausal for free. The government just says, we know you fare better and you'll have less threat of our medical system if you stay healthier, and hormones are part of that. So when women get menopausal in Finland, they just give them hormones for free. And then they have a cancer registry, and they have a cardiovascular registry, and they have a stroke registry. So she just took a look at what women over a 12-year period, what kind of hormones they were taking, which way they got it, and who ended up having trouble, who ended up having breast cancer, who ended up having stroke, who ended up dying. And every single time hormones were given vaginally, there was never any increased risk of breast cancer or adverse cardiovascular events. I sent that study to Jonathan Wright, and I think I've mentioned this study before, and we've sent it out to everybody. And he gives all of his patients vaginal. But when I do vaginal, I've discovered that it's much better divided into 2 dosages. So there has to be a patient who's compliant with doing that. But Dr. Wright only gives his vaginal dose once a day. I divide mine up into twice a day. But a vaginal dose gets your blood levels into the breast and into the lining of the uterus higher and more effectively, and the evidence is clear that it does it with a lot less pregnane metabolite production. So there are dozens of studies exploring the use of oral progesterone to protect the endometrium, and that's what Deborah said. But there's few consistent findings that shine through. So we do know oral progesterone can provide endometrial protection, but consistently the studies show that at lower dosages, such as 50 to 100 milligrams, there is still a risk of endometrial proliferation. Even studies of progestins are not perfect and will display small percentage of proliferative change. This is going in and doing vaginal ultrasounds and looking at these patients' uterine lining. As doses ascend to 400 milligrams of oral progesterone, the risk expectantly decreases, but none of the studies employing these high progesterone dosages extended their study to include examination of urinary metabolites. One study which we'll show a little further down, gave 400 milligrams of oral progesterone, and when they did vaginal ultrasounds, some of the women still had hyperplasia at 400 milligrams of oral progesterone. And here's all the different studies that support this of what this said. The Johnson study from 2002, where 336 menopausal women were given 1.5 milligrams of topical estradiol for 24 days, and then either a progestin or an oral progesterone, this was 200 milligrams, for the 14-month, when you cycle it in the middle of the month. Endometrial biopsies at the end of 18 months of treatment did not show any cases of hyperplasia, but did show some proliferative endometrium in a small percentage from both groups. So on 200 milligrams of oral progesterone, some of the women were having proliferative endometrium, which you don't want to have. You want to make sure a woman gets enough progesterone so her endometrial lining is not growing out of control. This is with 200 milligrams of oral. The stimulatory effect of estradiol potentially drives endometrial change, but there's a big debate about the dosage. And if you go to most compounding pharmacies, and Dr. Rosensweet said his sweet spot is ultimately from 0.8 milligrams of estradiol a day to 1.5 estradiol. I know Jim Hinseer, who's part of our membership, says he likes to go up to 2 milligrams. Well, then you need enough progesterone to oppose that supraphysiologic level of estradiol at the uterine wall. And you might not know that unless you do a vaginal ultrasound. But many say that the standard dose that makes women feel the best is 0.6 to 1.5. I think Dr. Rosensweet says 0.8 milligrams of estradiol a day to 1.5 milligrams of estradiol a day. I know that at my clinic, the average dosage is almost getting up to 2 milligrams a day. So is there enough progesterone on board to know that you're really protecting the uterine lining? And of course, if a woman doesn't have a uterus, then this is not of a question. In the olden days, they would say if a woman didn't have a uterus, you didn't need to give progesterone, because we only saw progesterone as the protector of the uterine lining, but we now know that it does so many other things. In standard hormone replacement, gynecologists give much lower dosages. They might give patches of 250 micrograms of estradiol for 24 days, which equates over the month to 6 milligrams, whereas if you look at what bioidentical practitioners give, they give much larger dosages over 24 days. So in essence, is the way that you're recommending hormones creating that negative estrogen dominance if there's not enough progesterone on board? And is your oral progesterone promoting this negative estrogen dominance because it's not opposing the estrogen that you're recommending? The Moyer study used lower dosed estradiol patches over 5 years, and they didn't report any hyperplasia or cancer, and showed reduced rates of endometrial growth by using much, much lower doses of estrogen. Okay, well, that makes sense. The lower doses you get, but in bioidentical hormones, we tend to give a little bit more. In another study, they used a 50 microgram estradiol patch with oral 100 and 200 milligram of progesterone versus vaginal 100 and 200 milligram of progesterone. And in none of those cases was there hyperplasia, but in bioidentical hormones, we're given much more than that. Interesting, they also reported that there were fewer bleeding occurrences in those taking progesterone vaginally. And that's because vaginal progesterone really does stabilize and oppose growth out of control much, much better than any other delivery mode. And if you have a woman that is bleeding and that's not from any organic issue, usually that means that if there's breakthrough bleeding, spotty bleeding, you're not giving enough progesterone. Not enough is reaching the uterine wall. So topical or vaginal progesterone avoids the first hepatic pass. In a follow-up study, these researchers applied the same topical estradiol patch to women taking 3 different types of progestins versus oral progesterone. So they gave 3 different types of synthetic progestins, and then they get versus an oral natural progesterone at a high dose, 200 milligrams. Then they followed the women, 100 women, for a year. They prescribed estradiol on a basis, but they only gave, like a lot of doctors do, cycling in the luteal phase, the progesterone. And what happened was 73% of the time they had breakthrough bleeding. And after reading all these studies, I don't really think in menopausal women we should just be giving progesterone in mid-cycle. I think it really should be, if you want to cycle it, which cycling is always healthier because it mimics Mother Nature more, for half the month it should be a lower level, and the second half of the month it should be higher. But if you're giving estrogen regularly, estrogen should not be given without giving progesterone. Otherwise, why are they having breakthrough bleeding? Because there is hyperplastic activity at the lining of the uterus. They also saw additional irregular bleeding and spotting. Altogether, it was in 92% of the cases. This is 100 women that they followed for a year, and there was not enough opposition by adequate progesterone, or they were giving too much estrogen. And oral progestins failed at a much higher rate than oral progesterone, which is interesting, at eliminating endometrial proliferation. This study used 2 milligrams of estradiol, while the Holt study used 3 milligrams of estradiol, which is getting a little closer. I get a lot of patients from LA, and they tend to dose very high in LA. It's very common for me to work with a woman who's on 10 milligrams of testosterone a day and 2 to 3 milligrams, if not up to 6, which is the old-time dose before tamoxifen, to treat metastatic breast cancer, because high doses of hormones downregulate the receptor. But what was interesting is the general finding was that the higher dosages of oral progesterone were more protective than the lower dosages and more consistently produced an atrophic endometrium. But this is the one I just mentioned earlier, but even dosages of 400 milligrams orally of natural progesterone did not completely halt proliferative changes from occurring. So this is the building up of evidence to show that oral progesterone in some women isn't going to really be protecting their uteruses. But remember that receptor is very malleable, and that malleability varies from woman to woman, 1 by her genes, and 2 also by whether she's exposed to plastics, whether she was exposed in utero to endocrine disrupting compounds. If there's already other competitive elements sitting in the receptor, there won't be enough room for the progesterone to get in there. That's why I showed those moving receptors, and that receptor functionality, which is really where the rubber meets the road of hormones, varies from woman to woman. And that's why some women might do fine with oral progesterone at night before bed and nothing else, and they don't have proliferative changes at the uterus, and they're really great. And then you might have a whole subset of patients that you're missing that really aren't doing that great on it. It's not totally clear cut because receptor functionality at this point differs from woman to woman so much. Factors that drive hyperplasia and proliferation of the endometrium are oral estrogen. When you swallow it, it makes more pro-inflammatory metabolites. If you give more estradiol than the body can use or that the progesterone you give can oppose. If there's excessive numbers of days of estradiol without protective presence of progesterone. So I'm no longer a big fan of just cycling progesterone just in the middle of the cycle if you're giving estrogen. If you have a perimenopausal woman and you're just giving her progesterone, then there's no problem. But remember, a perimenopausal woman has spurts of a lot more estrogen, so maybe there is a problem. Maybe she should be someone that for 2 weeks has a low, 25 milligrams of progesterone, and then the other 2 weeks you double it to 50 milligrams. Maybe we shouldn't be doing just that mid-cycle dosing of progesterone, because now we're seeing that it doesn't really give protection of the uterine lining throughout the entire 30-day month. If there's lack of progesterone tissue levels due to rapid metabolism of oral dosing, remember oral dosing makes blood levels of progesterone be very short-lived, and it doesn't get to tissues near as good like the breast and uterine lining as vaginal and topical doses do. And progesterone doses that are just too low or too brief. So this is what drives growth out of control of the uterine lining. Now, of course, there's other factors that disrupt the response to hormone replacement. If a woman is really obese, fat cells manufacture estrogen, and they mainly manufacture estrone, which is more an pro-carcinogenic estrogen. So the more a woman has fat cells, the more she will have a possible altered response to the hormones that you give her. So an overweight woman is going to need more progesterone than a thin woman. We learned I can't remember what talk we were just giving this in. I think it was just the live level. And we learned that fat-soluble vitamins, if you have a lot more fat cells, they stay stored in your fat cells, and they're not as available to be solubilized, which is how they're used. And all sex steroid hormones have retinoic receptors, and they need vitamin A to function. There's old-time studies where they treated menorrhagia with giving vitamin A. Just giving vitamin A boosted up the bioavailability of estrogen. So if a woman has a lot more fat cells, she becomes more complex to give her hormone replacement. And you're probably really going to need to really be very careful that you gave her enough progesterone. And you're going to need to give her fat-soluble vitamins. She might need a much higher dose than in other patients that are lean. And don't forget, you can be a thin fat person where you're actually pretty lean, but you've got a lot of visceral fat in your gut. So it can be a little bit difficult to diagnose who really are the patients with excess fat. I know when I was in Nashville, and I went to Dr. Houston to see him when I turned 70, and I said, look under my hood, and he measured our BMI, and my girlfriend that I was with was a nurse, and she's very thin, but when he did her BMI was close to the obese level, because actually in her abdomen she had so much fat. So thin, fatty, or a person with a lot of adipose tissue becomes much more difficult to balance all of these things out. If a woman drinks a lot of alcohol, alcohol is very estrogenic, so she's going to need more progesterone to balance that out. If they live a life with a lot of plastic exposure, or they use perfume a lot, most perfumes have phthalates, and phthalates are very estrogenic. And if they utilize a lot of carbonates and wash them in the dishwasher, that releases a lot of estrogenic activity. I remember when I was at Tulane, I think her name was Dr. Hunter, she took plastic containers that were polycarbonate with bisphenol A in them, and she washed them in the dishwasher, put water in them, and fed that water to pregnant rodents. And the next 4 generations were infertile just from the estrogen that leached from the BPA plastic just being washed with regular detergent in the dishwasher. So all of that affects how much progesterone somebody needs to protect their uterus if they're getting estrogenic compounds in other ways. And don't forget that soy is the only plant isoflavone that signals the anti-proliferative, anti-cancer ER beta receptor. So soy is not a contributing issue with promoting more estrogen and then possibly needing more progesterone to oppose that. And don't forget that receptors need a lot of nutrients to function well, so digestion and your biome. But if a person is exposed to a lot of chemicals in their life, they could have a lot of chemicals in their receptors. And when you give hormones, there's not enough room for that hormone because the shape of the receptor is changed and they can't get in. So there's all these other factors that we now have to really take a look at. And I just gave you some of the the studies here that show it. This one study showed that women who had lost weight significantly had a significant reduction in cancer weight because fat cells make the form of estrogen that's more linked to hormonally driven cancers. And obesity creates a deepening state of unopposed estrogen. Testosterone is breast protective and anti-proliferative. And I know a lot of gynecologists don't really take testosterone very seriously. They think it's basically just a libido hormone and it's hit or miss at that. And they often are reluctant, even if a woman gets her levels run and she's pretty low, to prescribe testosterone therapy because they don't understand that it's anti-proliferative at the breast, but only if it goes down the androgenic pathways. If a woman has a lot of aromatization and it's adding to estrogen, then it's not the same exact anti-proliferative protection at the breast. So the questions and answers that you might say around all this are, if I don't have a uterus, should I care? Well, yes, because progesterone does so much more. So in a middle-aged person, 35, 40-year-old person, the brain makes progesterone. Coronary heart valves make progesterone. Bone has receptors for progesterone. So it is very key in multiple tissues as a protective agent, and it's breast protective, and any woman choosing to use estradiol post-hysterectomy will be healthier with progesterone to counterbalance the effects of estrogen. And by the way, there's at least 20 studies that have looked at the level of progesterone in the blood of women going in for breast cancer surgery. And the women that have the highest level of progesterone in their blood tend to live the longest and have less recurrence. So when I work with breast cancer patients and they're going to go in for surgery, I always have them taking progesterone right before the surgery. No matter what, you want progesterone on board before going in for breast surgery. And if you just go into PubMed, it's so easy to find them. And I summarize a number of those studies in Safe Hormones, Smart Women. There's so many of them that it's really hard to believe that it's not standard of care to give a woman progesterone before she goes in for breast surgery. So progesterone is breast protective, brain protective, bone protective. So just because you don't have a uterus doesn't mean you don't want to get more of progesterone's protection. Topical progesterone, vaginal or oral versus topical. Progesterone applied to any mucosal membrane, oral or vaginal, will absorb roughly twice the efficiency as topical. Topical progesterone moves largely through the lymphatics so that there is a disproportionately high concentration of the hormone near the site of application. So you want, when someone does use topical progesterone, to have as much cream and cover as much area with fat in it and rub it for 1 solid minute, and the fat underneath the skin acts as a time release of that hormone throughout the rest of the day. Giving topical progesterone, the best way to keep the blood levels up is with PCCA's new base called Versa anhydrous. That base has been designed to help improve that time release function of a topical hormone better than almost any other base, where the vaginal base that's I think is the best is Versa base. But the one now to use on the skin that I think is the best, and it's only been around for less than a year. I think when I lectured at the PCCA hormone extravaganza last January. It was just being introduced, is called Versa anhydrous. So skin application, you want as much cream as possible. You want to go through a large area on the body and rotate it. You want to rub it in for a minute. But when you do it vaginally, I give many of my hormones in a ml syringe in 1/10 of a ml to 2/10 of a ml dosage. So there's hardly any cream, and guys wouldn't understand it. But if you have a lot of cream vaginally, you're sloshing around, your pH changes, you feel like you're prone to yeast infections. So it's the opposite of giving it on the skin. Skin, you want lots of cream, rub it in for a long time. Vaginally, you want to concentrate it as much as possible. And that's the way I take it myself, is twice a day in 1/10 to 2/10 of a ml application. And I also, on top of that, take some oral. And we're going to talk about all that because Deborah said, well, hey, that's expensive. So how do you deal with that? So the topical progesterone cream ranges from 10 milligrams to 80 milligrams, depending on the indication, the age of the patient, also the body size of the patient. If the woman's 300 pounds, you're going to want to give her, if it's topical, about 80 milligrams. That's the higher end of the dose. Oral could be anywhere from 50 to 400, but there's now a debate whether you should go much above one. Dr. Huber said 100. I try not to go above 150 much in my patients, but Katerina Dalton gave suppositories for many years to women in England of 900 milligrams, and but she gave it as suppositories, so she didn't see problems with an increased incidence of uterine cancer or uterine hyperplasia. But this is kind of the typical dose range. Oral, if you're going to do it long term, usually you want to start oral about 50 milligrams, and you want it to be sustained release. That's the best way to take it, depending on sleep outcomes. Above 100, Huber says you can start producing excessive pregnanes, but as I just said, go up to about 150. But I do have one or two patients. I have one woman who just could not sleep unless we went up to 400 milligrams of progesterone. And she slept with that for a year, and then that didn't work. And then we needed to put her on a medication. And then the medication finally worked, and we were able to lower the dose of the progesterone. And she didn't have any breasts getting larger at that dose. So what I usually do is, if someone feels like they really benefit with sleep, like I don't even feel like I can go to sleep unless I take progesterone before bed, but I feel like I need to have some other progesterone. I take my sustained release progesterone orally at night, and then I take in my several tenths of a mil with my biased. I have a little bit of progesterone added to that, so 20 milligrams BID. So I'm taking about 40 milligrams vaginally and then 100 milligrams oral before bed. And I know that that's a little bit more expensive, but I think that's the real Jaguar top of the line way of giving hormones. But if you give a hormone to a woman just orally and she doesn't have any problems, and after she's been on them for 5-6 months, you do a vaginal ultrasound and there's no hyperplastic activity, then she's one of the women who can handle it. Her receptors were just great. And even though her own personal metabolism of it allowed her body to eke out enough progesterone to protect her uterine wall. But you can't know just by a patient saying, I have no problems. You have to go in, if they have a uterus, and do a vaginal ultrasound. So I'm going to stop this. So, was Deborah on here? I don't think she was. Was that helpful? What do you think, Carol? About
Karen, I think it was very helpful, and even I'm not a prescriber, but the prescriber that I have been to, when I mentioned this to her, she was totally clueless, and she's all through A4M, and I thought really up on things. So I appreciate this information very much.
I don't think a lot of people know this, and I think it's pretty clear cut, but I don't think a lot of people know this, and it's important to get the word out because you want to make sure that that your hormones are in balance, and you want to make sure you don't get X. Now, I have to just tell you, I just heard this week from a patient. She was a woman who had stage 1 endometrial cancer. And I was working in Tulsa, Oklahoma, and with Dr. Block. And she was convinced if she had surgery, which of course the treatment is hysterectomy, definitely it's hysterectomy. She had had a surgery 10 years earlier and almost died. So she just was convinced if she had surgery, she would die. So we had her sign all kinds of releases and this and that. And we gave her vaginal progesterone and 2-methoxyestradiol. And we did that twice a day. And she's then she moved to Nashville. And it was really a trick to get her all that in Nashville. And we found a functional doctor who would work with us. And she kept getting vaginal ultrasounds. And within a year and a half, she had no evidence of disease. And the last year and a half, I've been writing her over and over again, how are you? How are you? I just want to know how you are. And last week, I got an email from her saying, I'm doing great. I feel like you guys saved my life. And I've had no endometrial cancer now for several years out. So that was, of course, we didn't tell her to do that, and she had to sign all this away. But the power of the vaginal progesterone, along with 2-MeO, 2-methoxyestradiol, twice a day. And she said for the last year, she couldn't get the 2-MeO. So for the last year, she's just been doing the progesterone. But now it's been like 4.5 years that she has no evidence of endometrial cancer. That's pretty incredible case study, right?
Absolutely.
So the power of progesterone is pretty amazing, especially at the uterine lining. But we didn't realize how maybe there can be a whole group of patients that aren't getting enough protection there, and it isn't enough to just say that they're doing okay. But and I think that in the next year we'll learn a lot more about these pregnine to pregnane metabolite ratios. But I've stopped running them because it just didn't seem to translate into the clinical use of it yet. But I know Dr. Wright's tracking a lot of that. It's been almost a year now that he's been running it, and it'll be interesting to see what he publishes out of that. So just kind of keep your ears and eyes open. But how many of you regularly do vaginal ultrasounds within the first year of a woman who's on HRT with a uterus? So that's something that you need to really change. That's like a big, that's a game changer. And you really need to make sure that whatever you're giving her, your endometrial stripe isn't going beyond 5. And you just don't know that till you measure it. Carol, I can't hear you. I think you're muted.
Can you hear me now?
Yeah, I can hear you now.
Okay. So obviously you would want to do a baseline vaginal ultrasound, and then what would be your next time frame for doing one?
Usually depending on when you get to the dosage that the woman feels good. You know how sometimes it's a journey to get to the dosage that she feels is right? Some women, you just give it to them. Men, you give them hormones and they feel right out of the chute. Mm-hmm. Some women, you give them hormones, they feel right out of the chute. Some women, it's about a year journey. So when they feel like they're pretty good, this is the dosage that I'm feeling pretty good at, that's the time to do the follow-up vaginal ultrasound.
I don't not do them. I haven't done them on a regular basis with my patients that have uterus. So
I know nobody seems to teach that. No. But when I took a course with Jack Monaco. He teaches a little bit for A4M, and that's where we met. Actually, one time we ended up being roommates together because we were stuck in Vegas, and he snores so loud I slept in the bathtub. So that's how I think of Jack Monaco, is sleeping in the bathtub, because there was only one room left at the Abagio or wherever we were at. But he was the one that first said, if you're going to give a woman hormones, you got to know what's going on with her vaginal lining. It's malpractice, he said, to not do that. And I never really, and now that I've done this deep dive, as you just seen at 400 milligrams of oral, there was still some evidence of hyperplastic activity in some of the patients in that study. That's like pretty amazing. That meant that there wasn't enough unadulterated progesterone coming from that high oral dose to help protect the uterine wall. So you just got to know what's going on. And this patient that I had, so she started with a troche and she had no issue. And then she went to a different compounding pharmacist because she moved to a different town and it was a larger troche. And then her endometrial stripe was 26, but just by giving more progesterone and changing the delivery route and giving DIM and methylfolate, the next time we tested her, she was back to 5. So you can get a really, but we still had her get a DNC. I mean,
Mm-hmm.
So, so that's important to know, that giving hormones, most of us aren't really tracking this, and we're not exactly sure of what's going on with our patients' uteruses.
Mm-hmm.
And that's critical. And that's where I think people can get sued. So I just thought that was a great question. So I didn't do the meeting yet on vaginal health.
No, thank you. Thank you. I have to fly here. I was just asking Sarah about what the dates were for January. I like to get them on my calendar as soon as possible.
Okay.
We're going to talk about that. Do you want to do that, Lindsay, or do you want me
to do that? Why don't you?
Okay.
You look so pretty. So let's look at you for a while.
Got my Christmas lipstick on. What we're looking at, Dr. Berkson's going to be starting back lecturing probably in March, so Saturdays would be out then. I know originally when we first started the membership, we were meeting the 4th Thursday of the month and needed to switch due to holidays coming up, for November and December, and switch to Saturdays. So don't know whether Saturdays are still the best time, whether Fridays, we did try to do that, but had technical difficulties that one Friday in November, whether Fridays or just go back to our regular scheduled Thursdays. So what's everybody kind of think right now, knowing that at least by March probably would have to definitely switch to a weekday time?
Well, we don't have a lot of people on this call, do we? We don't have a lot of people. I mean, people listen to this archived, but we don't. This is a small group today,
but
and
I think
it's a
most
Saturday.
Most everybody that's here today usually tries to make it every month. So I don't know, what are you guys thinking as far as?
We have about 20 people in the pro group, but we only have like 3 or 4 people that are here on, so I don't know if Saturday seems to be good or it isn't good because we have such a little live outcome. I don't know. What do you think, Carol? Is Saturday better for you?
Friday or Saturday is better for me. Thursdays are really hard with my schedule, but I'm just one person, so
I'd rather do a Friday if Friday was okay. So Karen, what do you think? And Sheena, what do you think?
I don't like Friday.
I couldn't hear that.
I don't like Friday.
Oh no?
Thursday is better for me.
What about Saturday?
Saturday's okay.
Okay. Sheena, what about you?
I'm pretty flexible. I'm pretty flexible.
Okay. So it sounds like it should be Saturday because that would cover all 3 of you that are here. So maybe the next time we meet, let's do it on a Saturday. There's a new message here.
And so Carol, we know that you have to run. So thank you for being here today. Hope you have a wonderful time with your girls outing for all that. And
thank you, Lindsay.
Yeah, don't forget, if you have time on Tuesday, I'll send out an email, Thursday the 24th, Dr. Berkson's birthday little celebration thing that we're doing, just to come and have a little cup of coffee or a cup of cheer and just visit for about 30 minutes and then go on with your day. But we'll send that out for the 24th.
Okay,
Awesome.
bye, Carol. Bye. blessings. And then someone asked Versa. So Versa anhydrous, the spelling is Versa. And then new word, anhydrous, 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 Versa anhydrous. And it's supposed to really help you put it on topically, but it's supposed to, because of the way that they did the matrix of the cream, it's supposed to keep the level of the hormones more even keel. And I just signed a contract with Biotics to come out with a female line, and I also have a product to keep the level of the hormones more even keel and to detox the receptors on an ongoing basis to make sure that there's a lot of malleability. So I, keeping all this in mind that we've been looking at this, I've been designing products to try and assist with this. So they'll be available supposedly by the end of February. The first two. Okay, well, thank you so much for giving us your Saturday. I hope you feel that this was helpful for you. And hopefully I'll see you on my birthday. And if not, that's cool too, no worries. And then we'll see you. And hope everyone is enjoying the Facebook postings too, because we've been having some very interesting postings, I think. Okay, blessings everybody. Bye-bye.
Bye.
Thank you.